Okay, so thank you very much for coming. Any guys that I know, a couple of guys that I don't know, so thank you for being here, ladies. Right, so welcome to one more event of the Center for Cognitive Sciences at the University of Nice. So I'm very happy to announce a distinguished guest from abroad once again. Okay, we have guests over the device over here, which is the video link very often, but we don't have the opportunity so often to get people to come over live and give a couple of talks. So we are very happy to have with us Dr. Ahmed Mustafe. Okay, I'll try some data from your biography, but if I make a mistake, please let me know. So Ahmed is currently making a tour through Europe, I think, but it's kind of a scientific tour in a way as well, because he's visiting in places that kind of have similar interests to his own research interests. And he is originally graduated from Cairo University in Egypt, then moved to the United States, stayed in the States for about 10 years or something altogether, got his PhD and spent some time there as a postdoc. Universities of Arizona, Louisiana, and Rutgers University, working with some really top-notch experts. Right now, okay, he's in Australia, right? University of Western Sydney, the position of a senior lecturer, which is like associate professor, more or less. That's the rank. Okay, and does research in cognitive and clinical neuropsychology, all kinds of interesting topics, understanding learning and cognitive function in various psychiatric and neurological disorders, including but not limited to schizophrenia, Parkinson's disease, depression, post-traumatic stress disorder, and so on and so forth. A formidable collection of papers. I don't want to start listing them. Okay, so places like Cognitive Neuroscience, Brain, Science, journals, Annals of the American Academy of Sciences, and so on and so forth. So really, papers in very nice places, and we are all too happy to have Ahmed here. So please, the floor is yours. Thank you.
Thank you. Thanks, Mark, for the introduction. I hope my talk will match up to your.
I'm so sure.
I mean, you put a high expectation now. We'll see. All right, so. So most of the work I do is actually the computational modeling and also cognitive testing with different kind of patient population. So one thing I want to say before I start, you guys feel free to interrupt anytime. We have like 2 hours, so we can, or even longer if you guys like. So, and I'm around for 2-3 days. If anyone wanna I don't know, chat, have a drink, whatever, talk about research, I'm around until Wednesday, maybe Thursday morning. All right, so today I will just talk mostly about Parkinson's disease. So talk about computational work we have done with Parkinson and also cognitive and cognitive testing with patient as well. All right, so so here's the outline for my lecture. First, I would just give you a brief introduction what exactly is Parkinson's disease. I'll talk about a class of computational modeling known as reinforcement learning models that we have been applying to different kind of data set from Parkinson patients, including something known as freezing of gait. Freezing of gait is a phenomenon that happens in Parkinson's disease patients. Basically, when patients, sometimes when they walk, as the term suggests, they freeze, like they be walking and then they cannot even take a step forward. They struggle with walking and things like that. So we try to understand this phenomenon using brain imaging and cognitive testing and computational modeling work. The other thing also, another project also I'm working on is impulse control disorders or impulsivity, the kind of issue that happen in Parkinson's disease patients, usually often because of the medication we give them. So before they were on medication, they don't have this kind of problem. When you put them on a certain class of medication, they develop impulsivity problems. So look at why dopamine medication is causing this and how it affects the brain and so forth. The third project, if we have some time, let's talk about a project I did before some years ago on working memory, how again Parkinson's disease and medication would give them affect working memory or short-term memory. And at the very end, I talk about deep brain stimulation. So here's the question: have you guys heard about deep brain stimulation? Anyone here heard about deep brain stimulation? Is it happening in Serbia? Any idea? No. What's that?
No, we are not using the
okay. So it is. So this project actually we do. I've done experimental work before in deep brain stimulation. Now we do computational modeling to understand how it works. The idea is actually you stick electrodes in different parts of your brain that depend on the disorder the patient have. So the patient was, whatever motor disorder, Parkinson, Huntington, or other, you stick the electrodes in the motor circuit to treat the disease. Usually you do it when the drugs do not work very well. For depression, you target the motivation or mood circuit. For Alzheimer's, this is dementia disorder, there are clinical trials, you target the hippocampus area, very important for memory. Anyway, it has been used extensively for many different kind of brain disorders, and again, you target different brain areas based on the disease people have. So, I mean, I've done only some work with this with Parkinson's disease patient. I'm going to describe some of it. Again, some of this experimental work, and also recently we have done also computational modeling work to understand the brain stimulation. All right. So briefly, what is Parkinson's disease? So Parkinson's disease is often as an old age disorder. It can happen in young age, but it's not very common. Often after age 60, 65 or so. And there's also a case of juvenile Parkinson. Again, as I said, it's not very common. The main class of symptoms we see in Parkinson's disease is these three categories. So one is rigidity or akinesia, and that what means rigidity means that Parkinson's disease patient, they're very rigid. So the neurologists usually hold their hand, try to move it back and forth, and it often doesn't go very smoothly. Usually they get this, if you have to kind of struggle to move their hand back and forth. So rigidity. Akinesia is like difficulty initiating movement. Resting tremor is actually tremor. I think this is the famous one, the shaking that happens in patients when they are at rest. Usually they have some kind of shaking in their hands or legs, maybe in their neck sometimes. And this is different from another kind of tremor called action tremor, when people start shaking while moving. This also can happen in Parkinson, but less common. Resting tremor is more common in Parkinson's disease patients. Bradykinesia is just a term for a slow movement. So anything like we, as presumably healthy, normal people do, we just, we can do it more quickly than Parkinson's disease patient. This term for slow movement, bradykinesia. So again, so this is most of the class of symptoms most Parkinson's disease patients have. Actually, you don't have to have all of this. So if you have subset of this symptom, you'll be diagnosed as Parkinson patient. And because of this, there's sometimes individual difference among Parkinson's disease patients. Some of them have very severe resting tremor. Some other ones have more severe akinesia than resting tremor. So we see a lot of individual differences among the patients. All right. So the textbook description or the pathology in Parkinson's disease actually is reduction of dopamine in the brain. The story is probably way more complex than this, but this is most likely what you will read in an introduction to Parkinson's disease or something like that. So dopamine comes from two nuclei deep in the brain stem. Sources are known as substantia nigra and ventral tegmental area, and they project dopamine to different parts of the brain. So you see here the red and the gray nuclei. They project to the basal ganglia, prefrontal cortex, and other brain areas as well. So because of reduction of dopamine projecting to the basal ganglia is a brain system important for motor control or initiation of motor processes. So when you have reduction of dopamine in this brain area, it makes it difficult to initiate motor responses. And this is the idea why we see the motor problem in Parkinson's disease patient. Okay. One important thing also, the basal ganglia actually has representation of all different kind of motor processes we do. So the representation of your hand, leg, eye movement, and so forth. If you can actually activate different part of the basal ganglia, you can be able to initiate different kind of movement in people. And because of reduction of dopamine in Parkinson's disease patient, most of the medication we prescribe to Parkinson patient that tend to increase dopamine level in the brain. That involve levodopa, also known as the golden medication in Parkinson. This has been around for about 60 years or so. MO inhibitors, another class of medication that also tend to increase dopamine, and different kind of dopamine agonists that work by just activating different dopamine receptors in the basal ganglia and different part of the brain as well, and tend to mimic the action of dopamine. All right, any question so far? Is all good? All right. So we know for about 20 years now or so that actually Parkinson's disease is not really only a motor disorder. There we see also a lot of like affective or psychiatric problem as well, and we see also cognitive changes in Parkinson's disease patient, and that's probably related to that. You know, when we have reduction of dopamine, it's also see reduction of dopamine also in the prefrontal cortex. It's an area important for different kind of cognitive processes, working memory and attention and so forth. The kind of affective or psychiatric issue we see in Parkinson's disease patient. So here's one important thing. This affective problem we see in the patient can be because of the disease itself or the medication we give to the patient. And that can involve, like sometimes we see hallucinations in Parkinson's disease patient. I mean, we hear also about hallucinations like in schizophrenia, but it's often happen in Parkinson, mostly because of dopamine medication. But it can be because of some other factor as well. Okay? Depression can happen in Parkinson's disease as well. And as I mentioned earlier, also impulsivity problems because of the medication we give them. All right, so the kind of research I do is the following. We test Parkinson's disease patient on and off medication. The reason that we test the patient, so what is on and off medication? First, like we tell the patient to skip. So first, the patient take medication about 3 to 4 times a day. We tell them not to take the night medication and the morning one. So they take the afternoon medication and they come to the lab. Say they take like this one at 4 p.m. and they come to the lab next day, maybe 9 a.m. or so, without taking any medication, and we test them. And that's almost long enough to be able to wash their bodies from any medicine, and we can test them whether this is the off state. And also test them in the on medication state, like they take the regular medication like 3 or 4 times a day, and they come testing, do whatever testing in the lab. And actually, by testing patient on and off medication, we see actually huge difference, even within the same patient. Not only at the motor level. Motor part, it's very obvious. When they're off medication, it's hard for them to drive to the lab. It is, it's just, you can see like their face, they can feel like not very comfortable, not being on medication. The tremor increased a little bit, things like that. But we also see cognitive changes as well when they are off medication. But the reason we do that is actually we can tease apart the effect from the medication from the disease itself. And in parallel, also we do computational neuropsychology, computational modeling work, and we try to understand the behavior data we have, and we try also to, the good thing about modeling, so you can also come up with predictions. So you explain the data you have, and you come up with new prediction for new experimental studies. That's basically the kind of work we do. So I'm going to describe briefly what is reinforcement learning. And it's a class of computational models that has been used extensively in computer science, and after that also in psychology and neuroscience as well. And we try to use this kind of models to understand different kind of behavior data sets from Parkinson patients. All right, so what is reinforcement learning? So basically the idea for reinforcement learning is that you do some kind of some kind of action, and you get some kind of feedback based on this action. And the idea that this feedback is actually reinforce the action you have done. So if you do something first time like this, you don't know what kind of outcome you get or feedback you get. If it happens to be a positive feedback, that can reinforce the action. So you keep doing it again. If you get negative feedback, you don't do it again, so forth. Why this becomes really important for the psychology and neuroscience, the group in Germany and the UK more than 20 years ago, they found that actually this teaching signal, or the feedback learning or reinforcement learning, is actually related to dopamine signals. Dopamine is playing a big role in this teaching signal, that's in reinforcement learning. All right, just as I described briefly the reinforcement learning model. So what's happening in the reinforcement learning model is, at every trial, you complete what's known as prediction error, PE, at the trial. We just call it trial T, and the prediction error is the reward you get at this trial minus the value of the stimulus at this trial. So as an example, first time I met Mihalu, my value of him was 0 because I didn't know anything about him. We went out last night, we had drinks, he paid for me, life is good. So reward, so I got, so reward is 1. So after this incident, so my value was 0, reward is 1, so prediction error was positive. What happened then, I update my value of him. So the new value at t plus 1 equal the old value plus some kind of learning rate time the positive error. So my value increase a little bit. And tonight I hope it's going to be more as well. We'll see. So that's the main idea of prediction. Everything has a value, and you compute the value based on the feedback you get. And then you do a choice in the model using again a standard equation known as Softmax Equation, which basically tells you that if I'm choosing between 2 things, if you have like something has value, I don't know, 0.6, something has another value 0.7, most likely you choose the one with the higher value, but not always. We have a noise, or like the beta parameter is a noise, like you can sometime that you can explore or use something with a lower value. We don't always go for the large one. So this is again the standard description of reinforcement learning model. There are tens of reinforcement learning model literature, but then have a little bit of variation around this description. All right, any questions so far? Good. All right, so this project I'm doing with 3 people, Simon Lewis, Rivana, and Vignesh. So again, this is a computational modeling work and experimental work. We look at freezing of gait. So let me first just explain, show you an example of what freezing of gait is. This is, you can explain it. This is an example of Parkinson disease patient. So here's a little bit of freezing. Sometimes happens when you try to make a turn. Right, so you have an idea now what freezing of gait is? So actually, so the interesting thing, actually, the main finding of the literature about freezing of gait is, it actually, even though it sounds like a motor problem, was actually causing it is actually like either perceptual or cognitive demand. When you increase the perceptual or cognitive demands on the patient, you make them freeze. Or actually, if you make them try to kind of a difficult kind of movement. So if you have a Parkinson patient walking in an open area, they will be completely fine. They may not show any freezing at all. But you challenge them, so like, here's an obstacle, you have to go around it. Then becomes a little, this for them is like, again, like making any kind of motor switching. This is the difficult part for them. So they have some kind of motor plan they're doing. They have to switch. It's not very easy. So if they are walking and they have to go upstairs. A little bit difficult for them because they have to change their motor plan. The same thing for turning. They are walking and then they make a turn. Again, it's not very easy. Or initiation, the same thing. They are sitting down and then they have to do some kind of different kind of motor plan to start moving. Again, it's problematic. But once they start moving an open area, no challenges, life is good. Okay? So the thing again about Parkinson freezing, it happened in mostly advanced Parkinson disease patients. Again, we can see it in early stage Parkinson, but it's not very common. More in advanced stage. It's also different. It's also different from the other kind of symptom in Parkinson disease. It's not a form of akinesia. It's not a form of bradykinesia because it doesn't correlate with any other kind of symptoms in Parkinson. And why it becomes an interesting topic actually, because actually the medication and the brain stimulation do not fix it very well. And also, do you hear something? Oh. It can also lead to falls and age as well. So Parkinson's sometimes they struggle with movement and they fall, and falling in old age is not really fun. So why actually we are so we started with one project actually that actually show an idea of how can actually changing some kind of the perceptual processes can actually affect freezing of gait. So there's a study actually that found that freezing actually can happen more when patients try to go through a narrow door than a wide door. If they have a wide door, they can just walk fine. If they have a narrower door, once they get closer, they start freezing. Even though they are told it's big enough to go through, but they still feel like it's a little bit of a challenge and they don't know what's going to happen, and they freeze more. And this is the result done by Coe et al. So the top figure is a Parkinson patient. The lower one is HUC is healthy controls, and you have the black line is is the door, and what you have here is like the velocity getting closer to the door. And you have the three different colors for the three different sizes of the door. So look at the lower one for healthy controls. Again, for the green and yellow one, this is the wide and medium sized doors. The velocity is okay even when you get closer to the door. There's a little bit of a drop when you pass through narrow door. Compared to the Parkinson's disease one, you see again there's a big drop in the narrow door. And sometimes there's a little bit of freezing in that part as well. So again, patients like these are going through a narrow door, it confused them. Okay, makes sense? So we started actually doing a computational modeling just like to understand this finding. This is what we started with. So and we use a reinforcement learning model, and in the model we have an agent, just like navigate around like a matrix. And what we use reinforcement learning also to train the model to act in this environment. In most computational modeling, what we do actually is, so first we build the computational model, and we assume, okay, this is a model of healthy controls, and we have a parameter, so in the model we have a parameter that represents like basal ganglia part, represent prefrontal cortex and dopamine, and we just decrease the value of dopamine in the parameter, the value of dopamine in the model, sorry. So instead of like say the dopamine value is 1, we say the value is 0.2. And this is the only difference we do in the model, and we say, okay, this is now a model of Parkinson's disease. And then we can run both models and see how different they are. Only one parameter would change its value. The key idea about this model is, so we have this agent, if it actually passes through the door, we assume it's rewarding, you get 1, and that's how we can use RL to link it to freezing of gait. If it hit the door, that during learning we assume, okay, this is negative, so you get R equal 0, and it's aversive behavior, and then you learn that I should not really hit, I should learn to pass through the door and not to hit, the side parts. However, but many, what happened in the model, by many collisions in the model, it actually leads a model that predict there's always going to be some approaching a narrow door, and it makes the model slow down. So again, here's the behavior data that I showed you earlier, and here's the computational modeling data. So as you can see, there's a qualitatively similar result, again, in the computational modeling figures on the right. Again, you see also in the healthy controls and the Parkinson part, we see a little bit of similarity. Again, it's the only difference I think between these two figures here is just a dopamine parameter that we decrease the value and we get this effect. So what we're doing actually later with freezing of gait as well, we try to also get the model of obstacle avoidance. We do also do dual tasking. There's an evidence that also that not only perceptual demands affect freezing of gait, but also cognitive demand as well. So if we have the patient that count backward from 100 by 3, we do whatever task and whatever mental arithmetic, whatever task in their heads, and they still them just to keep walking as well. And there's an evidence that also can lead to freezing as well. And also look at effective deep brain stimulation. So the reason also why this is happening in Parkinson's disease patient is this idea that there's two different kind of motor control system. So the habitual control system that's a rhythmic one. That's like that's we currently use when we walk. We don't think about walking. It's habitual for us. But for Parkinson's disease patient, the basal ganglia is not function, so they rely on a different system, kind of more like a thinking system, the cortex or something like that. But that's slower and it's not very efficient. So even if you add another cognitive task on top of this, it's hard to do both together. So this is one of the theories why freezing of gait happens in Parkinson's disease patient, or even why even their motor behavior is slow and impaired and things like that, because they rely on a different motor system in the brain.
They basically have to think about it in a way, consciously.
It's actually
something like that.
It seemed like a thinking process, but even by us observing patient, it actually seemed kind of like that picture. Sometimes you look at them, sometimes they look at their foot and they try really to, they think how exactly to do the next step and things like that. So I'm gonna move to another topic, but I want to ask if you guys have any questions about this before I move to that second one. Any questions? Okay. The second project we started to work on about 3-4 years ago. We started to look at impulse control disorder in Parkinson's disease. It became like a hot topic late 1990s because there were few drugs that were approved for Parkinson's disease patients, like Requip and Pramipexole, the dopamine agonist drugs. And after they have been commonly used, especially in the Western world, many patients develop impulse control disorders. This wasn't the case, so the report of impulsivity in the patients, the 40 years before or two, with any other kind of drugs, doesn't even match at all. So it seemed to be related to these newer drugs for Parkinson's disease patients. So again, so what is this project I'm doing with two PhD students, Yashar and Pam. So what is actually impulsivity in Parkinson's disease patient? What's actually happening is usually the partner of the patient, the wife or the husband, usually complain that her husband has really changed. Like, he's not the same like before. He's like, so I had one patient, like, he's overusing his credit card to do like online gambling, and he wasn't like this before. Sometimes like also overusing again their credit card to buy things they never need at all. Also, there's also hypersexuality. I don't have a picture here.
We get it.
What's that?
We get it.
I did Google it though, but don't do it. It's like it's terrible. Hypersexuality problems as well, and binge eating. So some of the patients, they show some of these symptoms, or sometimes even all of them. We see that in Parkinson's disease patient. Again, as I mentioned earlier, this actually seems to be happening because of dopamine medication we give to the patient. Yeah, go ahead.
So this is going to be a bit stupid maybe. So for younger juvenile Parkinson's,
yeah.
How is it recorded that they have changed? Is it recorded how they change in regards to this? So do they do something differently? Do they have some other things that they do? Play games maybe more or something else?
You mean before or after the medication?
After the disease.
I don't know about they play games more?
Yeah, video games, they usually...
You think this as a kind of impulsivity problem, you're saying?
Yeah.
I'm not sure about that. Well, first, we don't have really many juvenile Parkinson patients, so I don't even know anyone looked at. I'm not sure if even anyone has looked at this impulsivity in juvenile Parkinson disease. Could be, but I'm not sure. All right, this is what I mentioned earlier. So, since 2000 on, after the approval of Pramipexole and Requip, like impulse control orders have been happening more and more than the last 40 years or so. I'll probably skip this. So in this project, so this actually we study impulsivity. It's also computational and also experimental. What we're trying to understand is what's really causing impulsivity in the patient and what is the information processing mechanism underlying impulsivity. So we're seeing that impulsivity in Parkinson's disease patients, it could be related to what you call like hypersensitivity to positive outcome, or maybe or hypersensitivity to negative outcome. It's similar actually what we kind of see in addiction research. It could be that, like say like someone who was heroin addict or alcoholic or something. So it could be the case that you really like the alcohol or the heroin too much. So it can mean like a lot. Mean the value is higher than any other thing, or maybe also because of these people are hypersensitive to negative feedback. You get negative feedback because of addiction or because of impulsivity, but you don't really care about it. So say that if you're alcoholic, you may not sleep well. I don't know. You might gain weight. You might lose your partner or things like that. But it's like this kind of thing does not make you change your behavior. You still keep doing the same kind of behaviors regardless of the negative feedback you get. And we have a task, cognitive task, to look at this. It's kind of like learning from gain or loss task. So it says the idea is like to learn from, to do the action that lead to, I don't know, a carrot, like learn from gain, or actually learn to avoid the negative outcome. And the task is actually a very simple task. It's as following. So again, if you're a participant in the task, sit in the computer, this is exactly what you would see. First, you have a random stimulus. I ask you okay, choose A or B. The first time you choose randomly, say I choose A, but then you happen to get points. So it's good. The idea is to try to increase the number of points. So this is a good thing. So next time you see this stimulus, hopefully you pick it again. If you choose B, you get nothing. So this is rewarding stimulus. You learn to choose A for this one. You have another one on a different trial. Again, you choose A or B. If you choose B here, A here, you lose points. So you will learn not to choose A and you choose B. So you don't lose point. And the very end is try to maximize point and not lose any point and things like that. Is that clear? But actually, it's a little bit more complex than this. We have 4 stimuli. It's also the association a little bit probabilistic to make it a little bit more difficult to figure out. So that takes longer time. And we have 160 trials, and people you get one after the other in a random order until they figure out which goes with which. And actually, because it's a probabilistic association, sometimes even people actually learn the task without even being aware of what happened. Watch them at the very end. You remember which is good, which is bad. They don't know. They even feel they didn't learn anything. But look at the learning performance. It actually looks like they really figure out the associations very well without being aware of it. All right. So this is the experimental part. So what we find here is so we have 4 groups. It's actually 2 years or more data collection. A little bit of it's kind of hard to find all this patient groups. So we had 3 patient group and 1 control group. The first one from the right is ICD's patient with Parkinson patient with impulsivity. Plus means they have impulsivity. The second one, PD ICD minus, is patient for some reason we don't know. They were on medication, but they didn't develop impulsivity problems. The third one is Parkinson's disease patient off medication. And the last one is healthy controls. The Parkinson's division off medication actually they didn't have impulsivity before. We were hoping that another group of patients with impulsivity test them off medication, but we only end up with 2 or 3. We didn't include in the analysis, not large N for any kind of analysis at all. In the most studies on neuropsychology, you compare patient to controls, you make sure they match in education, age, and all of this. HY is a common ER staging, this is about how severe their Parkinson is, and you can see 2.5. This is early stage Parkinson, early to middle stage Parkinson, not very severe Parkinson disease patient. By the way, when the patient have the disease for a longer time and become really severe, it becomes really difficult to do any study with them. Because again, the tremor is very strong. It's very hard even to click any key or anything like that, And sometimes all the stages develop dementia as well. So it's even hard to understand the instructions in the task. It's the only thing here, Barrett impulsiveness scale is just the questionnaire that look at impulsivity in the patient. And as you can see here that the ICD plus group patient with impulsivity, they have increased impulsiveness according to the scale as well, which confirm they have impulsivity problems. and again forward the span and backward the span, like short-term memory task, and again we make sure they match and all of that. Okay, so this is the demographics and clinical information about the patient. And again, what we also have done also, we apply the computational modeling model to the data, known as actor-critic model. It's a modified version of the reinforcement learning model, and we applied and we get parameter value for every participant, and then we correlate it with the impulsivity in the patient. So the model, just like what we have done, is just we assume that the teaching signal, it doesn't only really reinforce the action, but can also reinforce the stimuli as well. So I did also reinforcement learning, even though historically has been applying for, again, the feedback like impact action. But there's a lot of research now, even like found that reinforcement or negative or any kind of feedback you get from the environment can actually increase attention to some kind of a stimuli. So if you happen to see some kind of a stimulus and you pay attention to it, and this can lead to reward at the end, that will increase your attention toward it. It can even increase your cognitive processes toward certain kind of stimuli. That's the main idea. So again, we apply the same kind of model, except again, it's this small difference. We have a critic that has two different kind of learning rates, not one. So we call it alpha gain in the critic, alpha loss in the critic as well. So the critic is the stimulus learning, learn about the stimulus in the environment. And the same thing also in the actor. Actor basically the learning to do the correct actions, or the correct action selection. And we have the same thing. But also we have two different also learning rate in the actor as well. So alpha gain actor and alpha loss actor. And as before, we have a softmax function for action selection. All right. So these are the three parameters we have in the model. We fit every model for every participant. We fit the model and we get the values. So okay, first we show you the behavior results. So from the data, we just look at after learning the task. We have 160 trials. We separate learning about the reward stimuli for learning about the punishment one or the loss one. We see how each group, and then we average them for every group. Okay, and we see how good they are in each one. So here's the interesting part. So they have four groups. As you can see, the brown one, which is the Parkinson patient with impulsivity, they're actually higher than the other group on learning from reward. They actually learn from reward really, really well, more than the other groups. Again, this is the idea like patients are always bad or anything. Sometimes, as you can see from this example, sometimes patient can actually do much better than even healthy controls with their own medication here. On the graph on the right, where they can see this learning from negative feedback. Other side, we can see also patient with impulsivity, they actually were lower. They didn't learn as good from negative feedback, also in comparison to the other group. Okay. So then we look at the modeling results. Okay, and the critic, learning the critic from gain, the figure on the left, there was no differences. Look from critic from reward learning in the actor, as you can see here that in the right figure, the medicated patient group, whether they're impulsive or not, they have a very high learning rate value than the other groups. We're expecting it would be different among the impulsive and non-impulsive group, but we didn't find any difference. But again, that's an agreement with medication enhancing action learning and enhance action performance in the patients. In the punishment learning rate, here's actually the interesting finding. You can see that also learning in the critic, in the ICD patient, the patient with impulsivity was lower than in the other group. Again, I mean, idea here that it could be the problem. So it could be actually here that the problem was with impulsivity is that the negative feedback they get. They don't really evaluate the negative feedback very well. So person with impulsivity, and actually we think the same could be also happening in addiction as well. That's the negative feedback they get. It doesn't really change their behavior. They kind of ignore it and they keep doing the same thing, get something negative feedback after the other, but it doesn't matter. They're still doing the same thing. There's actually some kind of new kind of behavior therapy and treatment in addicts that try actually to kind of like, to make people more sensitive to negative feedback. That might make them more responsive and they can maybe change their behavior more. All right. What we do actually in the future work in this project, we look at depression in Parkinson's disease. Actually, the idea actually here that depression might be the opposite side, the flip side of impulsivity. So we might see actually like increased learning from negative feedback, and actually the other way around for positive for reward learning. All right. Any questions so far about this part before we move to the other one? All good. All right. I'm gonna skip this working memory one, and I will move to deep brain stimulation. I think it's more novel and more interesting. But at the very end, if we want to talk about working memory, so we still have more time, we can do that. Let me just okay. All right, so as I mentioned earlier, so deep brain stimulation actually is again newer therapy. It actually has been it's used in kind of disorder for Parkinson's disease patient. You take medication for a long time, the medication causes long-term effect. Sometimes it doesn't work very well. It can cause like something known as like livedo, a dyskinesia problem. People start moving a lot the whole time. It's all kind of problem that comes with a long-term intake of the medication. And at this point, like, you really have to do something different. You can't just keep taking the medication. So this is the reason why it has been extensively used now for Parkinson's patients. For other disorders like depression and others, the medication doesn't even work at all for about, I don't know, maybe 40, the different report, 40% or 30, somewhere in the 65% something, in patients with depression never respond to medication at all. And there are people having like now doing deep brain stimulation as well for depression. It has been shown to be very effective for managing the symptoms. So again, just a brief introduction. For Parkinson's disease patient and other motor disorder, we target the basal ganglia. Again, you do the surgery, you stick electrodes inside the brain, the certain part of the basal ganglia, and it works magically well. Depression, you target the nucleus accumbens. PTSD, as far as I know, for PTSD, it is not approved yet, but there are clinical trials that show that PTSD, when you target the amygdala, which is a brain area that has been shown to be overactive in patients with PTSD and anxiety, they tend to manage the PTSD symptom as well. For Alzheimer, again for the hippocampus area, and as far as I know, also it's still under clinical trials, but it's not approved yet. For depression and Parkinson, it has been used for many years. Addiction also, we target the nucleus accumbens area. All right, so I'm gonna show you a video of a Parkinson's disease patient when on off and on DBS.
See important safety information at the end of the video. Only your doctor can determine if this therapy is right for you.
Just don't worry about this. So the patient before doing DBS, even they're on medication still, but there's a little bit, look at the right hand side, there's a little bit of shaking. Also the facial expression as well, there's a little bit of problem.
Want to take a look at how your tremor's doing? That's pretty darn spiffy. You're getting some effect from that other side, it looks like. That looked fine.
Here's to you, huh?
Here's to you.
Okay, you actually, so when I work with patients with deep brain stimulation, when I was at University of Arizona about 7 years ago, this was my first time interacting with the patient. It's actually magical. We also were testing them on and off deep brain stimulation. It was very hard to get actually ethics approval to do that, but we had there was a neurologist who was very interested in research, and it's hard to find such people now. They make so much money and they don't care about research. But anyway, he was quite good actually, and that's the first time I interacted with a patient. and he's come to the lab and he was turned off the DBS. Actually, there's a remote, like, actually, I'm kind of show you now. So let me show. Actually, here's what's happening. So they have like there's a battery here. It has like parameters, and you can actually adjust the frequency and the pulse width, all the kind of parameters like for the deep brain stimulation. And then you have the remote control to adjust it. So once you turn it off, it's like within few seconds, we have this patient, their tremor was like really, really severe, even more than the one in the video here. And then the tremor was less like this, and they're like, the posture instability was just really crazy. We can't even sit down, they're like kind of jumping all around. It's really terrible. You want to say something?
Now I understood the question. The electrodes go inside the
Yeah,
brain?
yeah, yeah. So as you can see here in the
So
fig.
they undergo surgery or something first?
Yeah, yeah. Well, you do like a first like a surgery. You stick the electrodes inside the brain, and you do another surgery. You put the
So those are in as well?
this actually and the stick and the wire go on. You don't see the wire. You see it here, but you don't really see the wire at the end. And then it's like push, and then you have the remote control, and you can. And sometimes
You were able to turn on and off the deep brain stimulation during the experiment.
yeah, well, this is what we did in this study. Yeah, we turned off.
During the study, you turned it on
Yeah,
and
yeah,
on.
Yeah. We turned off just to see, and then we just then report like the motor effects, and we look at also cognitive effect as well. But again, not many studies looked at this because again, it's a little bit just. When I have been trying last 2 years, but just I couldn't really get this started on any experimental work. Again, it's not very easy to get approval, to get the neurologist on site to do that and all of that. Yeah. But yeah, the surgery, you open the skull actually, and you stick electrodes inside.
I'm sorry, that's one question. What do patients feel while that machine is turned on? While that process.
What do they feel?
Yes. Are they conscious or?
Yeah, I mean after the surgery.
Yes, after surgery. After
Yeah, I mean,
inserting that.
they are conscious on and off. They were at the lab when you turn it off, and we test them. They feel they are aware of what's happening,
Yes.
but they are very uncomfortable with like in the tremor increases and the guys like keep jumping around and things like that.
Okay.
Does that answer your question?
Yes.
Yeah.
So, technically speaking, it doesn't help them permanently, and do the tremors actually lessen as time passes?
No, it helps them.
When you turn off the.
No, but this stays on. The battery can last for a year or two, and they come after 2 years. They put a new battery, and they like.
Have there been any
like,
problems while people had the device on?
What's that? So,
Like a brain pacemaker.
yeah, exactly. Yeah, that's like a pacemaker. Exactly. Yeah. No, they're a little bit. Actually, this study actually will look at there's some kind of side effect, but like a really, really minor side effect. But the benefit like you get with it, it's, 10 times more. 10 times more than the side effects that comes with it. And some years ago, there, sometimes people die, because 1 in 1,000, doing the surgery. Because I don't know, when you stick the electrode inside the brain, you might hit something like the brain stem, you kill the person or something. But it's not very common. But managing the symptom, again, in depression or in Parkinson's disease is very, very effective. Yeah, keep it on all the time, and you also give the remote to the patient, the remote control to the patient as well. But they have limited, they cannot turn it off, just you can change a little bit if you feel bad or things like that, But also, it is it is to adjust the parameters. It's a try and error. No one knows what is the best parameter for every single patient. You just the patient comes to clinic, or let's try frequency 150. If it manages perfect, if not, keep decreasing this. Maybe and you do it, you go home. They can't sleep well. They have some other kind of problems. They come back again after a month. You keep adjusting until you find, keep finding the best.
So let's say after we find that perfect middle, I guess.
Yeah.
So
It can.
do we need to change it later on?
Yeah, well, yeah, the disease is actually, I mean, Parkinson is a progressive disorder, right? So it changes over the time, you know. So at some point, you know, you will change it again, yeah.
And what was their status about medications? Are they off the medication during the study or not?
That's a good point. It varies from patient to another. So some of them, you always decrease the medication, and in few cases actually you can just take them off medication altogether. But this is not very common. That the majority of them is like you put like a lower dose of the medication. Right. So in this study, what we looked at is there's evidence actually like, oh, the area targeted is a small nucleus inside the basal ganglia known as a subthalamic nucleus, and this is actually not the only target of deep brain stimulation, but it's the most common one. And the evidence, like, you know, one of the side effects that happen because of DBS actually is impulsivity problem as well. So people become a little bit more impulsive. I think it comes like, you know, the idea is like, you know, you have like, you know, the threshold for initiating movement is like kind of high. It's hard for them to initiate movement, but DBS kind of lower the threshold and becomes like, you know, they can not only initiate movement, but they do kind of also impulsive behavior as well. Yeah. And what we did, like, you know, we develop a task, look at impulsive decision making, and here's the task. The idea is like, you know, I asked, we have two conditions. One we call known as high conflict condition, and one is known as the low conflict condition. And this is actually a task that developed by my supervisor, then Michael Frank. High conflict is like, you know, and I gave you two like this like decision like really like good, like really close to each other. Like I said, okay, you want to go to Paris or Rome? If I ask you this, you might take, I don't know, a few seconds to decide. You know, it's not very easy decision to make. But ask you like, okay, like, I don't know, go to Paris or like, you know, sit down in Nice and write a grant. You're like, now I'll go to Paris, and this is easy. You just like, you quickly decide and you make a decision. That's the main idea of the task. But of course, to do it in an experimental setting, this is what we have. This is what we have done. Again, the task developed by my supervisor then. So we have like different kind of stimuli, and this is this number, the reward value of the stimuli. So you train one stimulus, okay, it's really good, 80% good. Every time I tune the stimulus, I get 80% reward. Another stimulus is only 70%, and so forth. And people keep learning this by trial and error. They learn the value of each stimulus. And then I ask people, you will choose between this and this one, which one you choose. Again, this tool, remember, this is like the 80 versus 70. So you both have very high value, and a choice here is not very easy. And low conflict one, you have like just two stimuli, but both of them, again, one is 80, one is 20. This is the very easy one. That's low conflict. Again, sometimes you don't have like an awareness of this, but it's because of the learning they have done before. They develop this the behavior they have later. So these are the results. Here we have 5 patient groups. So the first one from the left is seniors with healthy controls, and then we have Parkinson's disease patient off medication. The third one, Parkinson's disease patient on medication, and then we have 2 other group, patient off DBS and patient on DBS. Again, because we have to compare medication to DBS to make sure it is not only any treatment can cause it, it's actually DBS itself. And as you can see here that for most of the even control and patient group, that everyone take longer time in the high conflict than the low conflict, which makes sense, right? Like again, 2 things like really close to each other, you take more time to decide on what exactly to do. Except the last one, the patient on DBS, they didn't actually do that. They didn't show. They took actually even less time in the high conflict condition than the low conflict condition. We're actually expecting that it will be at the same level, but for some weird reason, it was even lower than in the low conflict one. And the idea here is actually they really respond quickly, even in a high conflict condition. They don't take their time to decide what is right, what is wrong to do. So after this last 2 years, I was working with a PhD student in actually to build the computational model to understand, again, impulsivity, why DBS causes impulsivity, in this task. And actually, the good thing again about computational modeling is again we have more freedom with the model than we have with patients. So we can really play around with the model, the modeling parameters, and we can see actually how we can treat impulsivity in the model. That can give us idea, maybe for future work, how can you deal with it in real life. So we built a computational model of the basal ganglia. This is just like a circuit of like, think about this, like if you guys are familiar with connectionist network, probably study this a little bit. So again, like you have different layers and they have connected to each other different ways, and we train the network to do certain kind of behavior. That's the main idea. The only difference between this kind of modeling and connectionist modeling that we try to follow biology a little bit. So if we know like the certain area have certain kind of connectivity, we do this in the model. Again, so this is the model we design. Again, in the model we have like a representation of every part of this model. Again, as I mentioned before, we simulate Parkinson by decrease the dopamine parameter value, and we apply DBS in the model as well. We're seeing that DBS just apply electricity, a subset of nodes in this part of the network. And we measure reaction time in the model, basically how many cycles it takes to initiate a response. This is a standard way of measuring reaction time in connectionist model or any kind of network modeling. So here's the behavioral result. Again, it's not exactly the same like the one we have from the behavioral result, but again, when you apply DBS, you can see in the model it can actually lead to what we think is impulsivity, both in patient on DBS in the model, in Parkinson model. Again, there's no difference between high conflict and low conflict. So what we try to do in the model is, we actually try to get the model to do exactly like this, like the seniors, to spend more time in the high conflict. I don't think this would be beneficial. So again, we play around with the model parameters to see exactly how we can get this output. And here's, so what we have done is, we said, maybe activation will apply DBS to different part of this part of the basal ganglia, it might affect performance. And this is what we have done. We apply DBS to different part of the subthalamic nucleus. And here's actually the results. So the original one, DBS, you can see this as before. You have I think it's impulsive. It doesn't take much time in the high conflict. When we move the DBS to a different place, we can make it look again like controls. Again, we think this probably can help with reducing impulsivity or DBS-induced impulsivity. All right, so this is actually just a prediction of the model that, maybe when you move around the electrodes, that it can probably help. You can actually manage the symptoms. We also did model tremor in the model, and we can see how DBS can help with tremor and things like that. But also this has implication. Actually, when you do the deep brain stimulation surgery, you actually stick 4 electrodes in this part of the brain. And also you only activate one or some of them. This again depends on different kind of patient. But the idea is that maybe activation of different electrodes in the deep brain, in the STN, might have the effect on impulsivity. All right, so just the summary here that Parkinson, this summary of everything I said so far. So Parkinson is not really a motor disorder only. As I mentioned, that there is all kind of symptoms that come with Parkinson. Working memory is one. We didn't talk about this. Also, attentional problem. Some other kind of symptom that happen in Parkinson's disease, affective problem as well, depression, hallucination, impulsivity. And we use computational modeling here to understand how Parkinson and medication affect these processes, and how can we come up with predictions. All right, thank you. And we can have time for discussion, comments, questions.
Okay, thank you so much. So, guys, questions, comments? Book.
Have you tried any of these studies on patients with schizophrenia? Because because they have the problem with the cholinergic system also. So
There are clinical trials as well looking at deep brain stimulation on, I think, the hippocampus is a target for, I think some part of the hippocampal region have been a target. Oh, you're talking about
stimulation, but the models of these experiments?
We did some of this, yeah.
Yeah.
The thing also with schizophrenia, like data is like very messy. Like there's like we did the same like reward punishment task, and in one study we didn't find any differences, but some other people find like various kind of difference. We think it has to do with the effect of antipsychotics and maybe difference between the newer and older antipsychotics. They work different in the brain and things like that. So, but I think the story is not very clear for how schizophrenia affect this kind of processes.
And have you tried with different medications to see the effects of different medications and to model?
That's a good point.
Like levodopa compared to some dopamine agonists.
I've done some modeling, look at the difference between levodopa and dopamine agonist. However, experimentally, again, it's not very easy. And we don't really have much. It's hard to get ethics approval, like say, like patient, okay, like for the sake of experiment, like I switch them from levodopa to dopamine agonist. Also, another problem that most of the patients actually are on multiple therapy, different kind, a mix of the medication, and there are only very like a few studies in the literature that compare some to the others. But it's not. It wasn't very easy to do this kind of study. But for most of this study, actually, they found that so either levodopa alone or levodopa with dopamine agonist can do better, at least on cognition, than dopamine agonist itself. There's not a problem that comes with the use of dopamine agonist, at least on the cognitive processes.
Okay, I'm going to do humanities. Okay, so I'm kind of thinking about the epistemology behind the whole thing. This looks like kind of extreme behaviorist thing to me. So it's like no, it's okay. It's perfect. It works and it's just fine. But like, it looks to be aimed at alleviating symptoms, basically.
What's
the idea of making a model or doing the brain stimulation that will help those people get through the door and stuff like that, right? Have you thought about anything like, does it deal with the causes of the disease or as well?
What is causing the disease?
Yeah, what's causing the disease? Is there any chance that a therapy could help deal with the cause as well?
Well, I think that cause was one of this very difficult question. I think it probably has to do. I don't know. It's like there are people who have kind of like a bunch of genetic, markers have been found.
Like 200 factors or something.
I mean, you got the point. I think. Okay. I honestly don't know very much, but I know that something here and there, there's some kind of lark gene and different kind of dopamine genes have been found, related to the incidence of Parkinson, especially juvenile Parkinson is more common. There's a big genetic factor underlying juvenile Parkinson disease. There's a whole other group of people look at neurotoxin and their effect on Parkinson as well, and so it just could be a mix of all of this. And I think if we really have a clear-cut answer, I'll be super millionaire by now.
Of course.
Yeah, go ahead.
I'm thinking about drug addiction and obsessive compulsive disorder, which have the same neurophysiological substrate in the reward pathway when dopamine is high, but in Parkinson's disease it is low. And I answered how is possible to have connection between impulsivity disorder, which is connected with high dopamine, and Parkinson's disease when we have low dopamine.
Yeah, well, that's exactly. We see the symptoms actually in Parkinson patients when they're on medication. When you increase dopamine level, you get impulsivity problem. So it is actually kind of relevant.
It is the consequence of medication, the consequence of the disease.
Exactly. Yeah. We don't see impulsivity in unmedicated patient.
The other question: you differentiate the direct and indirect pathway of the influence of stimulation of direct and indirect pathway.
Which one?
Basal ganglia.
Oh, yeah.
Yes, I saw that you stimulated subthalamus, and it is
Exactly, yeah, exactly, yeah.
And you have the better results stimulating indirect pathway. And have you differentiated the dopamine 1 and dopamine 2 receptors on indirect pathway?
Okay, so you're talking about this figure, right?
Yes.
Yeah. So actually, DBS is actually applied to the STN, which is actually in the indirect pathway.
Mm-hmm.
So actually, we're trying to simulate the data out there. There are a few things about and actually and also out of study, D1 receptors are more common in the direct pathway, but D2 on the indirect pathway, right? And there's a few things about how exactly they work. So many ideas, people the direct pathways for initiating motor response and the indirect pathway for inhibiting responses. So we simulate this just because if we want to simulate the effect of DBS on the STN, that's why we had to have the indirect pathway in the model, because this is the target of the DBS. I mean, there's some other target of DBS like the thalamus or like the globus pallidus, things like that. I'm not sure. Did I answer the question or not?
Yes.
Okay.
Sorry. Well, I didn't really understand the difference between medicated patients and patients with deep brain stimulation concerning the difference between high and low conflict.
Yeah.
Could you put the graph on?
This one?
Behavioral, yeah. So there is a expected difference on with the patients on medicated patients.
Yeah.
Yeah, where the high conflict requires longer reaction times, but what is the difference between deep brain electrostimulation and stimulation using medications, so that we get that difference in the reaction times, so opposite? Do you understand my question?
Yeah, so I mean, we think the DBS kind of actually interfere with the indirect path, kind of applying a noise or inactivate the subthalamic nucleus, somehow kind of interrupt the activity or the information flow in the indirect pathway. No medication more just increase dopamine levels in the brain. I'm saying this, but I'm kind of hesitating because there's also evidence showing that also DBS increased dopamine level, like a rat experiment. We have no idea how it happens, but also DBS also increased dopamine level, but probably does more than this, and maybe this is why we see some different. That's the idea. But at least in the computational modeling work we did, we just assume medication increased dopamine level, but DBS is interfere with the indirect pathway, and that's how we get the results. But again, I don't think this really capture everything is happening, because I don't think just DBS is only doing this. There's a lot of effect happening as well. It's more complex than what we have here. It increases dopamine, it interferes with the next pathway, it does many other things.
Yeah, this is really interesting to see the opposite results. Treatment.
Yeah, we're actually happy with this, because actually we were hoping that there's not any treatment will go the same thing. We're saying it's specific to DBS and not to medication or other things. You had the question, right?
Is it possible that this is going to sound again very stupid to simulate without medication to increase dopamine in that person without actual medications?
With our study found exercise can increase medication. There's certain kind of food that increase dopamine. Certain kind of beans and some other things can actually tend to increase dopamine levels in the brain. Some kind of traditional medicines in Egypt and India and certain places, they use this kind of therapy. I know actually some of the patient actually, one problem sometimes with levodopa or some kind of medication, they have a short like half-life. They wear off quickly, and the patient like, you know, you were told us to take the medication like 2-3 times a day. So they say like, you know, after the morning one, like 1 or 2 p.m., they eat like sweets and chocolate and things like that, you know, kind of like sustain them till they can take the second one. I mean, the idea is probably this makes them more comfortable. It probably also increases dopamine level.